doing, and is presenting on the topic and the project today. If you want to put some information about yourself in the chat, just to introduce yourself to others, then you're welcome to, but don't feel like you have to. And what we're going to do today, as you've already heard, the recording started, is we're going to have a presentation from Jeannet, which will last around 20 to 25 minutes, and then we'll have around about half an hour to 35 minutes for some discussion and questions afterwards. And we are recording it, so the idea being that the presentation itself, not the discussion and questions afterwards, I hasten to add, will be uploaded onto our new platform fairly soon. I'm not quite sure what our timing will be, but fairly soon, and then you and others will be able to access it after the event. So just also to give a little bit of a health warning, as with many things, just a reminder to look after yourself, and if you find any of the content distressing or triggering in any way, please just take a moment to take some time and have a break. So I'll hand over to Jeanette if you'd like to put your presentation up and
Brilliant.
Tell us all about it.
Thank you. Excellent. Thank you very much, Rachel. That's great. Right, so I think I do it like that. Can you all see that okay?
Yep.
Yeah? Okay, so yeah, I'm Jeannet Weurman, part of the project group, and I'm going to tell you a little bit about trauma-informed working. It's quite basic level, but it's still useful, I hope, and a bit about our project and how we're trying to work to get trauma-informed working into hospice and palliative care. So yeah. So the way that this got started is that we noticed in hospices that some people might not get referred at all, but even people who do get referred might find being in a hospice environment quite difficult. And when people repeatedly failed to attend, they would be discharged. So when we tried to get a sense of who these people were, often they were people living with multiple disadvantage, which, as you probably know, is people living with two or more of a range of life challenges, such as mental health issues, homelessness, offending, and substance misuse. And there is a strong established link between multiple disadvantage and trauma. Now, this should move on when I tap it, and it's not moving on. Why isn't... Ah, there we are. So Barbara Hansel, in 2016, wrote a paper in which she noted that there's a high prevalence of trauma in the population generally, but it's also higher in some subgroups, including older people and palliative care patients. And of course, those groups are particularly well represented in hospice and palliative care. So people come in with trauma histories, but then there's a process whereby they sustain further trauma, or can do, because of being given a diagnosis with a life-threatening illness, being in pain, and medical interventions. So trauma, again, you're probably familiar with this, it's overwhelming events or circumstances which are experienced as harmful or life-threatening, which can have a lasting negative impact on the person's functioning and their mental, physical, emotional, social, and/or spiritual well-being. And childhood trauma is particularly damaging. It causes permanent changes to our brain structure, and it can affect our stress response system, so that people end up primed to respond to trauma reminders in typical ways. And that can include living with a level of hyperarousal, getting triggered into re-experiencing aspects of the past trauma. They can be avoiding trauma reminders, and that could include medical settings. There could be negative changes in thinking and mood. People can emotionally numb themselves or become numbed, and they can dissociate. So what is traumatic, of course, depends on the event, how it's experienced, and its impact on the person. But people can end up living with a baseline of low-level fear and functional impairment. And trauma-related symptoms can negatively impact what we think of as a good death. So there are a number of factors that affect access to services. One element we've touched on, which is the people with experience of trauma, and often they have reduced social support and they can find it quite hard to trust and communicate with professionals. The second aspect is the care system as a whole, and there's also hospice and palliative care settings and staff, how those operate and function. And all those factors together create a situation where there's reduced access to some people. People can suffer further trauma from diagnosis and treatment. There can be complications in doing a life review. People can find it harder to accept death. There can be increased distress and exacerbation of pain, and we wondered whether trauma might contribute towards total pain, and definitely a reduced well-being. So there's also a risk of something called healthcare re-traumatization. Stephanie Dallum defined it as a process in which evocative elements or events in healthcare replicate stimuli or dynamics associated with childhood trauma, causing survivors to be overwhelmed by post-traumatic stress symptoms related to the original trauma. And she says re-traumatization is actually a very frequent occurrence, but it tends to be hidden because people don't necessarily tell you when they feel triggered or challenged.
Yeah.
So she developed something called the healthcare re-traumatization model in 2010. She'd been looking and found that there was no clarity on how to recognize when trauma symptoms are triggered during healthcare encounters. So she said that we need a conceptual model to understand the difficulties patients face and to guide research and clinical practice. And she did a meta-synthesis of childhood sexual abuse survivors' experiences in healthcare. Lots of papers representing 15 qualitative studies, lots of interviews, and the resultant model was revised based on the input from 8 experts. So in that model, Stephanie notices a cyclical process of re-traumatization that involves 4 sub-processes. There is a hypersensitivity to threat. People then get exposed as they enter the healthcare system. They get exposed to triggers. That causes post-traumatic stress reactions, which then obviously is unpleasant, and then they avoid further experiences or things that might trigger them. So avoidant coping gets triggered. This is just a schematic depiction of the same thing, which I won't talk you through just in the interest of time. But as we say, this is all going to get uploaded, so you can look at that if you want to later. So this tells you about the avoidant coping. The key factor in the re-traumatization cycle is the coping strategy of the survivor. So on the one hand, there is avoidant coping, which is trying to avoid the triggers, escaping from them, which can involve dissociation, denial, submission, hostility, numbing, and healthcare avoidance. And that reinforces the re-traumatization cycle. And then there's also proactive coping, which is finding positive healthcare solutions that minimize or eliminate triggers. So patients need to be able to recognize the triggers and plan ahead and self-advocate. And as staff, we need to support them in doing that. We need to recognize and respect the survivor's safety needs to break that cycle. And again, a schematic depiction of that. Then a year later, David Feldman developed or published something called the stepwise psychosocial palliative care model. So this is specific to palliative care. The previous model of Stephanie Dallum's stuff is more general healthcare. This is specific to trauma intervention at end of life. And he says there are 3 stages to how we can work with people. and you only move to the next stage if the trauma symptoms haven't resolved, and also depending on a person's time, stamina, and willingness to go ahead. So the first step, because very often people at end of life, they haven't got the time or energy to act for themselves, is for staff to take action on behalf of clients and alleviate distress as much as they can. The second stage is to offer the person tools that they can use on their own to cope with distress as it arises. So it's a kind of psychoeducation and coping support. And very important, David says, to normalize people's symptoms, because people can feel quite ashamed of having them. Then before you go on to stage 3, you need a kind of preparation point, which is to look at the effectiveness of the previous interventions. Is there a need to do anything more? You need to diagnose or assess for post-traumatic stress disorder, and also assess the person's energy, prognosis, ability, and willingness to continue. If all those things are positive, then you can go on to stage 3, which is either provided within the palliative care service or hospice setting, or it involves a referral to a specialist practitioner, but it's treatment specific to full threshold post-traumatic stress disorder. And because it involves thinking and talking about trauma memories, you're less likely to do that kind of work with hospice patients because they have a limited time, and it can make symptoms worse before they get better. So David also talks about something called the universal precautions approach, which other people have also highlighted as a good thing to do. It's using a trauma lens relating to everyone in a way that assumes that they may have trauma. And that's because people may not be aware of trauma that they've had and only become aware when they get triggered, or they may just not feel ready to talk about it. And in any case, at end of life, people have limited time and energy, so it may not be appropriate to put people through a process of formal diagnosis. And in any case, even if people don't have full post-traumatic stress disorder, lower level symptoms, trauma-related symptoms that don't meet those diagnostic criteria, can still cause significant distress, and they can still lower somebody's quality of life and make it difficult for them to receive healthcare in later life and at end of life. So the universal precautions approach allows us to recognize trauma and address it without needing to have an actual diagnosis. So where has all of this got to? The USA seems to be way ahead of the rest of us. I'm not going to read through all these different publications and organizations, but remember the first one, the US Substance Abuse and Mental Health Services Administration, SAMHSA, which has outlined specific characteristics of trauma-informed working, which we'll come on to in a minute. There's work going on in other countries, and we're very keen to link up with anyone outside of the UK who is working to develop trauma-informed practice in palliative care, in the hope of maybe we can collaborate or at least we can find out about each other, which would be good. Looking at the UK, Scotland is way ahead of the rest of us. Their government has trauma-informed policy for all public services and a toolkit and training to develop a trauma-informed workforce across all public services. So that's really quite stunning. The rest of the UK, things are developing, and there's certainly trauma-informed working in a number of services like mental health or children and families, a range of services. But as far as we know, there's no specific research into trauma-informed working in hospice and palliative care. Hospice UK have done a really good report on equality in hospice and end-of-life care a couple of years ago, and they're now doing deep dive studies into specific areas of disadvantage, like homelessness, mental health problems, and so on, people in prisons. But they didn't specifically highlight, although they mention it, trauma-informed working as an area of specific interest. So there are some good initiatives, but trauma-informed practice hasn't been widely adopted in hospices so far. So here are those 6 principles of trauma-informed care that were developed by SAMHSA. It's safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical and gender issues. So these are some suggestions for trauma-informed practice based on those kinds of principles. And the core of them, and I won't go through them with a fine-tooth comb, but the core of them is to enable trust by changing the relational dynamic between patient and provider on all levels of the system. So we need to show respect and build rapport, which can involve slowing down, taking time listening, not pathologizing challenging behavior, and thinking about how you engage with someone. We need to be sensitive to abuse-related issues, that trauma lens again, assume that people have experienced trauma, and use non-threatening open-ended questions. Be empathic. We'd all be doing that anyway, empathic and compassionate, and be curious about people. Ask what happened to you rather than what's wrong with you, and find out what would help the person make the service more accessible to them. We need to share power and control, ask for permission before we do interventions, not rush examinations, share information, give patients a choice, provide continuity of care, not constantly different workers, and appropriate referrals. Written instructions can be really helpful because when you're stressed, you don't absorb information terribly well. So it's good to have something written that you can take away, and make appropriate referrals to trauma-informed professionals. And we need to recognize the dilemma of disclosure. We can't assume, as we said before, that if somebody doesn't mention it, that there's no history of abuse or trauma of some kind. And don't press for unnecessary details. So this is, again, I won't go through it, but a useful sort of table with different triggers, the safety needs that lie behind the triggers, and potential therapeutic actions that you can take. So how are we taking this forward? So far, we've been supported by the Association of Palliative Care Social Workers to run social groups with its membership and also with Hospice UK. We've set up a project working group and developed a project plan, which involves building a community of practice and a virtual resource library, promoting research and development, working with experts by experience, and getting funding, which at the moment we haven't managed at all. And we noticed one possible idea for follow-up. We checked with a lawyer and she said there could be mileage in this. Could we argue that trauma is actually a characteristic which services need to take into account before deciding somebody's refusing services and discharging them, a bit like other protected characteristics? And then, should services have to make reasonable adjustments, i.e. by trauma-informed working? We've published a blog through the European Association of Palliative Care, and we've developed links to Caroline Schulman and Bryony Hudson. They have an initiative around palliative care for homeless people, and we've presented at their Palliative Care and Homelessness Echo. Our community of practice is an informal network just to share experiences, interests, information, and resources. And we're really excited about a communications platform that we've launched through Mighty Networks. It's free to use, so all you need to do is click on a link to register, and the link is on the first slide of this presentation, but you can also contact us and we can send it to you. We will use the platform to make announcements about events and notifications or other notifications that might be necessary. You can enter a profile of who you are and your interests so that other people can find you and can collaborate with you or just have discussions. You can start discussion groups, you can direct message other people, share information and resources. There are different spaces to post on special interests like EMDR, or we were talking about maybe we need something on preparing children for the death of parents. Anything we think is important, we can create a space for to discuss it and explore it further. And what we would ask is that if you post I don't know, articles or videos or something onto the platform, please check that it's generally available for free on the internet, because we don't want to fall foul of copyright laws. So it's a network for mutual support and sharing. Researchers can use it as a resource for collaboration and access to research subjects. So we'll be organising a community of practice meetings once a quarter, which will have a sort of format of a couple of short presentations, 10 minutes each, by members. So if you're interested in presenting, let us know. You could present a case study or a piece of theory, or maybe an issue or a dilemma that you've encountered. And then after those presentations, we go into small groups for I can't remember how long, 15, 20 minutes or something, and then a large group discussion and questions for the speakers. So the meetings last an hour and a half. And then on the halfway points, in between the quarterly community of practice meetings, we'll have quarterly webinars like this one, which will be a recorded presentation by members on a range of topics that we can then upload onto the platform, so that it becomes a kind of an information and training resource, and people can at any time use it with their colleagues or use it for their own information, or however they want to use it. We hope in the future we'll develop training further, but we're not really at that point yet. So with respect to research, we clearly need a strong evidence base to bring about changes in policy and practice. There's a lot of research on trauma, but there doesn't seem to be much on older people and end of life and trauma. A lot of the literature also focuses on veterans, and as we said, we need information about other particular groups of people that face specific problems. We're forming a research and development support group. Beck Salama is starting a 3-year PhD studentship, which is a mapping study around trauma-informed working in hospice and palliative care at Lancaster University. And we've contacted a load of universities that run doctorate in psychology courses, and a couple of them said that they'd be very happy to put our research questions to trainees as possible topics. They have to do a piece of research as part of their training. Where we've come a cropper is that we haven't got field supervisors. We've got research sites, but we need people who are willing to supervise the trainees. So if you know of anybody who might be willing to do that, please get them to contact us. And we can also all work on a smaller scale and then upload what we find onto our platform. We can try out different ways of working and keep records, or we can write up case studies, anonymized obviously, and we could develop our hospices as hubs for local communities of practice to develop trauma-informed care across agencies, where we're liaising with other agencies and getting referrals through. That the idea of trauma-informed working sort of has a ripple effect out across those agencies. Elizabeth Rix Ahern, a couple of years ago, said we specifically need research on what events and traumatic stressors have the greatest impact on trauma-related symptoms, and on hospice utilization, pain management, and quality of life at end of life. So maybe certain types of trauma have more of an impact than others, but we don't know that at this point. We also need to look at how we might need to adjust diagnostic criteria for trauma-related symptoms. And that goes back to the point that, even symptoms that are sub-threshold for post-traumatic stress disorder can still have a really significant negative effect on people. We may need adjusted assessment criteria and scales, and studies specific to people with dementia, but others, other groups as well, people with autism. The possibilities are endless. And then we need to have better research on trauma interventions that are effective, like maybe modified protocols for existing therapies like EMDR, prolonged exposure, and trauma-focused CBT. I think that's the end of the presentation, but there is a list of kind of references for anybody who wants to read a bit more, and I will stop the share. Great.
Thank you, Jeanette.